Hello everyone, and welcome to today's webinar in the RCPCH-BPSU Rare Condition series. Today, Dr. Claire Payne, Dr. Daniel Finn, Professor Robert Moots and Professor Paul Brogan will be presenting Behcet syndrome in children and young people. The presentation will last for approximately 45 minutes and will follow with a live Q&A with the presenters. You are able to submit your questions throughout the presentation via the Q&A option, which can be found by clicking or tapping the question mark icon on screen. We hope you enjoy today's webinar. Thank you.
Fantastic. Thanks everybody for joining us today, and thank you for the Royal College and the BPSU for setting up this rare disease webinar. So it's an overview of the session that's happening today. I think the key point really is that we've got a live Q&A panel at the end of the session, so please put any of your comments or questions into chat and we'll endeavour to answer those at the end. So I'm Claire Payne, I'm a consultant paediatric rheumatologist at Alderhay, and I led the BPSU study and also lead the paediatric Behcet service. The BPSU study has just been published in Rheumatology, but I'd like to thank our funders for making this study possible. So what is Behcet? So it's a chronic inflammatory syndrome. The hallmarks are recurrent oral ulceration, eye inflammation, genital ulcers and skin lesions. It's a vasculitis, but what's slightly unusual for a vasculitis is that it can affect any size blood vessel and can affect veins as well as arteries. The map at the bottom here shows the silk route, and this is a condition that's much more prevalent in those countries that are involved in the silk route. So there's no diagnostic test for Behcet, and there's a number of different classification criteria that can be used to help us think about whether a child may be affected by Behcet. One that's quite commonly used is the ISG criteria. In this, you need to have recurrent oral ulceration plus two of the following: recurrent genital ulcers not due to eye inflammation, and this is typically anterior posterior uveitis or retinal vasculitis and can lead to visual loss; skin lesions, which are described as erythema nodosum, pseudofolliculitis or papular-pustule lesions, or acneiform nodules, and a positive pathogy test. And the key at the bottom here in red is that there's no other meaningful clinical explanation for these group of symptoms. There's a number of different criteria that I'd like to bring your attention to as well. So the revised ICBD criteria is what we used in the BPSU study. And in this, you need to score 4 or more for Behcet's diagnosis. There's also some paediatric specific classification criteria also. What's different for these two criteria based on the ISG is you don't need to have recurrent oral ulceration. And you can also see they've added in neurological and vascular manifestations. What's different about the ICBD is that you can score on having, for example, just 2 organs involved, but for oral ulceration or ocular lesions would score you 4, whereas the paediatric criteria and the ISG, you need to have at least 3 different organs involved. So what were the aims of our BPSU study? So like all BPSU studies, we wanted to look at incidence, but we predicted that Behcet was going to be extremely rare, so we also wanted to look at prevalence. We wanted to know what the presenting symptoms were and clinical features, what the delay between symptom onset and diagnosis was, and what the pattern of care was for children, who they were seen by, how they were treated, and we also did a follow-up questionnaire at 1 year. We had 149 cases reported. Of those, 56 were definite, they met the ICBD criteria of 4 or more. 69 were excluded, and this is common in BPSU studies, but there were a number that were duplicate reports, some that didn't meet case definition. For example, they might have been out of the age bracket we were interested in, and a few where we didn't have the questionnaire returned. This left us with 24 patients who didn't fulfil ICBD criteria, and we termed indeterminate. And these are ones we wanted to follow up 1 year to see if they'd accrued other features that therefore meant they met ICBD criteria. Bottom line is that Behcet's is rare in UK children, with around 13 children a year developing Behcet's, with slightly more girls than boys affected, and most children were from a white ethnic background. 25% had a family history of Behcet's in a first-degree relative. The median age at first symptom was around 6 and at diagnosis around 11, leading a median time between first symptom to diagnosis of around 3.5 years. This is actually much less than some of the published adult studies. Mucocutaneous involvement was the most common in our UK cohort. Although you didn't need to have mouth ulcers to be part of to fulfil ICBD criteria, all children did. We had a much higher rate of genital ulceration than some of the other paediatric cohorts that have been published, and skin involvement was seen in half of the patients. This was most commonly pseudofolliculitis or papulopustular lesions, then erythema and a number of children had skin ulcers. Vascular and neurological involvement was rare, as is seen in other paediatric cohorts. Apart from genital ulcers, there was no significant difference between males or females. We saw more genital ulcers in girls, and there was no difference between ethnicities. I've also put these manifestations in this arrow form because children more commonly presented with mouth ulcers and genital ulcers than some of the other features. In terms of eye involvement, anterior uveitis was more common than panuveitis. We only had one case of retinal vasculitis and one case of visual loss. But I think what's important in terms of eye involvement is that a couple of patients had asymptomatic eye involvement that was only picked up on slit lamp screening, and 2 children started with eye involvement and then got a diagnosis of Behcet's later on. Neurological and vascular involvement was rare. We had 1 case each of a venous thrombosis and an arterial thrombosis, but no significant CNS involvement with no parenchymal or meningeal involvement. Some of the other manifestations that were described was arthritis, abdominal pain and diarrhoea. We had very little fever in our cohort. It's difficult to draw any conclusions from pathogy or HLA-B51 because it wasn't done that commonly. So of the children that did have a pathogy test done, which was only 12, 25% was positive, and HLA-B51 was only done in 3 cases and was positive in 1. The diagnosis and management of children with Behcet's is complex, and this can be seen here with over 80% of children being seen by 3 or more different specialists. And if you look at graph B, the number of children that were seen by 6 or more healthcare professionals. In terms of treatment, around 10 weren't on any treatment, and 10 were managed only with topical treatments such as steroid mouthwashes or topical ointments for skin or genital ulcers. However, around 30% required 1 or more systemic immunosuppressant. This table here compares the treatments at baseline on that first initial questionnaire and then 1 year later. What's important to remember from the baseline data here is this isn't just incident cases. There are some children here with established disease. What you can see in terms of trends is at 1 year there's less use of steroids and colchicine and more use of immunosuppressants, particularly azathioprine and anti-TNF. Out of anti-TNF, around 2/3 of children were treated with adalimumab and 1/3 infliximab. So what happens at 1 year follow-up? Around 12 children accrued new manifestations, 3 of which scored them extra on the ICBD criteria with skin and uveitis, and the others had accrued more non-specific features such as headaches, fatigue, and 2 had developed arthritis. If we go back and look at those that didn't fulfil that ICBD, initially those indeterminate cases, only 1 had progressed to fulfil ICBD during this year. So I just wanted to talk a little bit about the Older Hay Behcet service. In 2012, there were 3 national centres of excellence set up in Liverpool, Birmingham and in London for Behcet's, and that includes both paediatric and adult care. In Older Hay, we run a 2-monthly MDT clinic, and some of the key members of this are pictured here. In particular, we have input from oral medicine and gastroenterology, as we found there's often an overlap with potential diagnosis of inflammatory bowel disease, and oral medicine pick up a lot of subtle clues in the mouth that we may miss as paediatric rheumatologists. We have a paediatric dentist in the clinic who is key, as a lot of children struggle with dental hygiene because of mouth ulcers stop them being able to brush their teeth. We also have links to the adult service in terms of an adult rheumatologist and a support coordinator, which cover both the adult and the paediatric service, and means that transition is easier for patients. We also then have the wider rheumatology MDT, and we also have other specialists that we have shared clinics with. If, for example, there's eye involvement, we can see them in a joint shared uveitis clinic, and we also have links with neurology, gynecology and dermatology. I just wanted to bring your attention to the fact that the national centres cover commissioning for biologic drugs for paediatric Behcet's. We don't need to see your patient, but if you have a patient that you think warrants biologic treatment, there's a form to complete, and the links are here on the website, and we can approve biologics if we feel appropriate. In February last year, we were lucky enough to run a Children and Young People and Families Day funded by Behcet UK to develop information leaflets for teachers. There's some artwork at the bottom here that the children and young people developed with us, and what was key was that they didn't want to be defined by their illness, but also that their illness was often invisible to others and they may not appreciate how unwell they were feeling. Some of the other outputs from this day was that children and young people wanted information about the condition in different formats, including animation and vlogs from other young people, and we're working with the charity on these. So in summary, Behcet's diagnosis and management is complex, working together across specialties, but also with our adult colleagues and in partnership with children and young people is key. In the UK, the commonest subtype was the mucocutaneous variant, but we really need more research. We're about to open to the first clinical trial in paediatric Behcet's, but we need more evidence on effective and safe treatments. We also need to understand and improve the burden of disease for children and young people. Thank you.
Hello, my name is Daniel Finn. I'm a specialty trainee in oral medicine at Liverpool Dental Hospital, but I also work with Dr. Payne and Professor Moots at the Paediatric Behcet Clinic at Alderhay Children's Hospital. Today, I've been asked to provide an overview of oral ulceration in the context of Behcet's syndrome. The aims of this talk are to outline the clinical features of oral ulceration in paediatric Behcet syndrome and highlight some of the other common causes of oral ulceration that you may see in clinic. I'll also discuss the management of oral ulceration in the context of the paediatric Behcet's patient. I want to start by highlighting that there are numerous causes of oral ulceration, and that in fact Behcet's disease is a rather uncommon one. This mind map provides a broad overview of the causes of oral ulceration. One of the simplest points from a history is whether a patient is experiencing a single ulcer or multiple ulcers, and whether these are persistent, recurrent, or of a single episode. In patients with Behcet's, we would expect patients to have recurrent episodes of ulceration, and whilst patients can present with single ulcers, generally they will have multiple ulcers. For patients with multiple recurrent ulcers, there are a number of conditions that this could be related to. The most common of these is recurrent actus stomatitis, but there are multiple other causes of actus ulcers, which we will cover in more detail shortly. For conditions such as oral lichen planus and amenobullous diseases, which can present with ulcerative lesions in the mouth, these are quite rare within the paediatric population and would be differentiated clinically and, if required, histologically from Behcet's. As I've already mentioned, actus ulcers are probably the most common oral mucosal condition, affecting about 25% of the population at some point. Actus ulcers may begin with a prodromal tingling or burning, followed by erythema, and then ulceration. Acti tend to be well defined with an erythematous margin and a yellowy grey base. As these ulcers heal, the erythema reduces and the margins may become more irregular. When a patient presents in clinic complaining of recurrent oral ulceration, it's important to take a detailed history to help classify the ulceration and help achieve a diagnosis. Common questions that we would ask patients would include the age of onset of ulcers, the number of ulcers, and where they occur in the mouth. We'd also ask about their size, duration, and frequency. A very useful question is to ask patients, how long are they free from ulcers, as this will give a reasonable indication as to how much these patients are affected by ulcers. We also ask about trigger factors and previous treatments, as well as family history, which can be found in Behcet's disease, but also recurrent active stomatitis. As part of our review of systems, we will ask for associated symptoms which may raise suspicions of inflammatory bowel disease or celiac disease, other hallmarks of Behcet syndrome, or other conditions that are associated with oral ulceration. The history will help you categorise the type of aphthous ulcers a patient is experiencing into one of three main groups. Aphthous ulcers can be classified into minor, major, or herpetiform type based on their clinical features. Minor aphthous ulcers are the most common. These tend to last up to 2 weeks and generally are less than 1 centimetre in diameter. They tend to heal without scarring and have a predisposition for the non-keratinized tissues in the mouth, such as the tongue, labial, or buccal mucosa. Major aphthous ulcers are less common, but tend to be larger and heal with scarring, affecting both the keratinized and non-keratinized tissue in the mouth. Herpetiform ulcers are rare. Patients tend to have very small pinhead-sized ulcers that may coalesce to form a larger ulcer. These seem to have a predisposition for the ventral tongue or the labial mucosa, and contrary to the name, are not caused by the herpes virus, and the name is given because of their similar appearance to a primary HSV infection. This slide illustrates how aphthous ulcers may be classified based on their etiology. Most commonly, when patients present with aphthous ulcers, we are unable to identify any underlying disease. However, these patients may have some predisposing factors to their ulcers. This group of patients we would term recurrent active stomatitis. Some of the predisposing factors include genetics with a positive family history. Sometimes trauma to the oral mucosa can lead to ulceration. In patients who later stop smoking, they develop aphthous ulcers. And patients report stress and hormonal factors such as the luteal phase of menstruation as being triggers. Where patients experience ulceration that is clinically identical to RAS, but there's an underlying systemic cause, these are termed aphthous-like ulcers. And some of the causes include Behcet's, gastrointestinal disorders, hematological disorders, or other autoinflammatory syndromes, but the list I've shown here is by no means an exhaustive one. So, in the context of paediatric Behcet syndrome, patients may have any of the three types of aphthous ulceration I've already described, with 3 episodes per year. Oral ulceration in the paediatric patient is often the first manifestation in Behcet syndrome, with an average age of onset of between 8 and 9 years old. And quite importantly, it can precede other symptoms of Behcet's by nearly 4 years. In terms of managing aphthous ulceration, firstly, we always advise patients to avoid any precipitating factors by ensuring they have good oral hygiene, to use unflavoured and sodium lauryl sulphate-free toothpastes, and to eliminate any trauma such as sharp teeth. So it's important that patients have regular dental checkups with their general dental practitioner. Moving forward, we would start with topical treatments before progressing on to systemic agents. In terms of topical treatments, first-line therapies would include benzidamine mouthwashes or sprays, or other topical anaesthetics. Chlorhexidine can be used as an antiseptic to help reduce secondary infection. And barrier gels like Orabase or hyaluronic acid can be used to help alleviate symptoms. Moving on to topical corticosteroids. For patients who have isolated ulcers, or for young children who are not able to reliably use a mouthwash and spit it out, we would advise using either mucoadhesive hydrocortisone tablets or sprays, which common forms include beclometasone inhaler or fluticasone nasal spray, sprayed topically onto ulcers. For patients who are a little bit older and able to reliably spit out mouthwashes, options available include betamethasone sodium phosphate soluble tablets or fluxanase nasules. Either of these is dissolved in a small amount of water and used as a mouthwash. Doxycycline is also a useful agent in children over 12 years of age because it has anti-inflammatory and antibacterial properties. I'm not going to discuss systemic therapy in any significant detail. However, the management of actus ulceration and mucocutaneous disease in Behçet's tends to begin with colchicine before progressing to azathioprine and anti-TNF therapy, with oral steroids being used to achieve control when the condition flares. Personal experience of working in the paediatric Behçet clinic is that a lot of patients present with oral ulceration with gastrointestinal symptoms. And looking at the paediatric Behçet's disease study, about 40% of patients had non-specific GI symptoms. And the average age of onset of these is about 9 years old, which is very similar to the oral manifestations. Both inflammatory bowel disease and Behçet syndrome share other extraintestinal manifestations too. So there is a significant overlap with the symptoms, and I've screenshotted a paper here which highlights the similarities and differences between the GI manifestations of both conditions. And this really highlights the value of liaising with our colleagues in gastroenterology in helping achieve a diagnosis. It's important to note that both Behçet's and Crohn's disease may present with actus-like ulcers, but there are additional manifestations in the mouth that may present in Crohn's disease, and these include ulcers that can appear sulcular. So you can see here there is a sulcular ulcer within the lower buccal sulcus. The patients may develop lip swelling and fissuring of the lips. The buccal mucosa may appear thickened or cobblestoned, and there may be other features such as mucosal tags, enlargement of the sublingual tissues, and full-width gingivitis. Orofacial granulomatosis, or OFG, is a condition where patients have very similar features to oral Crohn's, but with no current evidence of intestinal Crohn's. However, they are at risk of developing this later in life. You would not expect to see these sorts of features in a patient with Behçet's, and if these are present, further investigations into possible inflammatory bowel disease should be undertaken. For further resources, including patient information leaflets on managing actus ulceration, please visit the British and Irish Society for Oral Medicine website. Thank you very much.
Hello, thank you for inviting me to take part in this really exciting webinar. I'm Robert Moots, I'm a rheumatologist, and I'm director of the Liverpool National Centre for Excellence for Behçet syndrome. In the next few minutes, I'm going to be really focusing on the treatment of Behçet. But to understand this, we've really got to get right back to first principles. And here we have a really weird disease with a name that people can't pronounce and a lot of ignorance as to what causes it and what the treatment can be. I'm going to address a couple of these issues now over the next few minutes. First of all, if we're going to treat a disease, it's kind of helpful if we understand a little bit about the background to it. One of the problems with Behçet's is that we don't really understand that. In fact, we don't even know whether we should call it Behçet's disease or Behçet's syndrome. Technically, it's a syndrome, but I'm going to just call it Behçet's because that makes life a lot easier. One of the cardinal features of Behçet's pathologically is that of a vasculitis. And you can see here on the right, we start at the top and we can see a normal artery. And as inflammation develops in the artery, it can become narrowed, occluded, or aneurysms form. And Behçet's is an unusual type of vasculitis because it can affect not just arteries, but also veins. And also it can affect any size of blood vessel. And that's very unusual for the vasculitides. When we think about the underlying pathological processes at the cellular and molecular level, then this is really complicated. You can take almost any cell that you like, or any pathological process, pathway, cytokine that you like, and there'll be evidence that that could be important in Behçet's. So not surprising that the treatment's not great when we don't really understand what's going on. It's certainly likely to be multifactorial, although when we think genetically, and Paul Brogan's going to go into this in more detail, the largest genetic association is with the class 1 MHC molecule HLA-B51, and then the second one is ERAP1, which is also involved in the immune system. So that's about all that we really know with regards to the cause. So how does that help us with treatment? Well, probably not a huge amount. Many years ago, this was the treatment for Behçet's. People would be given drugs that actually caused more side effects than the disease itself. And a good example was thalidomide. So we've got to be careful that we're helping patients and not just poisoning them. And one of the big advances over recent years has been the development of biologics for other diseases, and actually understanding that a lot of the biologics that we use for other conditions can be helpful in Behçet's. But we still don't know what the ideal drug is, and our patients still worry about what's being pumped into them to try and relieve these awful symptoms. One of the things that we've developed in the UK has been a national drugs pathway, and I want you all to write this down and memorise it. Just joking, just want to show you here that when we developed the 3 centres of excellence, we actually have, for, at least for England, the drugs budget for all the high-cost drugs. And in order to administer this in a sensible and appropriate way, we have a drugs pathway that really shows with mild disease, we start with simple treatment and then work up, if necessarily, to biologics. But in the really acute organ-threatening disease, we can now start straight away with a biologic drug. And in England, these are all funded by the national commissioners, and that takes away all the previous problems with postcode prescribing. So you can see this pathway on our website. Just go to the National Centre's website. One of the issues, though, is how do we extrapolate this for children and young people? And Claire will have said a little bit about this, and Paul may say a little bit more. But that's one of the issues. This was devised for adults, and for children and young people, some of these drugs are not appropriately licensed, and in others we don't really know the right doses. So that's one of the challenges. And the other challenge is, apart from not really understanding the cause of the disease, it's really sad that at the moment most of the treatment is eminence-based with very little evidence. Our strategy is to try to use the lowest dose of safest drug for shortest time, and that could mean just treating a flare in some people, or it could mean background treatment in others. We have to differentiate between what would be organ-threatening, potentially causing blindness or strokes or things like that, versus what we might naively call nuisance symptoms. Although to people with nasty refractory ulcers, that's more than a nuisance. Problems can be acute or chronic, and the treatment would change accordingly. I'm not going to go into any detail with pregnancy, but I'm going to say just a little bit about the role of biologics in Behçet's, because that's been a very big advance. First of all, the overall strategy, if you want to look up the EULAR, that's European League Against Rheumatism, we took part in a consensus meeting and a very detailed, rigorous analysis of treatments with systematic reviews, and we published this a couple of years back. You can look at the details there. It actually, perhaps surprisingly or not surprisingly, maps very closely with our national drugs pathway in the UK. The key thing when we're thinking about treating Behçet's is first of all to get the diagnosis right. And that can be a challenge, particularly in children and young people, where it can come on in a stuttering way and not everything at once. We need to treat the patient as a whole, manage it as a team, and remember the baggage that can come, not just for children and young people, but their parents and families, particularly with the development of genital ulcers. When we think about drugs, first of all, we've not got to poison people with side effects. You may laugh, but that's been a problem in the past. And of course, try to do good. And one of the crucial things is that with the development of the National Centres of Excellence, if you're having a problem with somebody who you think has got Behçet's, we're around to help. Give us a call, give us an email. We're there to help advise you, help support the patient. And in the case of a biologic in England, we can authorise funding for that. So what about the future? Well, I've explained what's going on at present. It's not ideal, but as we look to the future, we're moving down a phenotype approach. And with regards to the general strategy of treatment, on the whole, we'll start with the simple immunosuppressant drugs and topical treatments. But if somebody needs a biologic, the first line treatment is likely to be a TNF inhibitor. But now we're finding that other types of anti-cytokine drugs can be useful in different situations. For example, if patients have got mucocutaneous, articular and enthesopathy type disease, but they don't have eye or GI disease, then IL-17 inhibition with drugs such as secukinumab are what we tend to advise. If it's vascular disease, then IL-6 inhibition with drugs such as tocilizumab can be helpful. And if there's overlap with inflammatory bowel disease, then drugs that inhibit the IL-12/23 pathway, like ustekinumab, can be very useful. We also have a small molecule, apremilast, which is a PDE4 inhibitor. That drug can be helpful in people with mucocutaneous disease, perhaps as an alternative to a TNF inhibitor. So when we think about Behçet's, it's challenging when we don't know the cause. There's a Nobel Prize in it if you want to try and work out what's going on. We've got new approaches over recent years with the formation of interdisciplinary, multidisciplinary clinics at the 3 centres of excellence. We're doing clinical trials. We're moving away, I do hope, from eminence-based treatment to evidence-based treatment. So I think already we're seeing outcomes in Behçet's improving. And I'm hopeful that over future years, with better treatments and a more targeted approach, the outcomes will get better still. Thank you.
So many thanks to the previous speakers for the lovely summary about Behçet's disease and its presentation in UK patients so far. This presentation will discuss whether, in fact, the diagnosis of Behçet's disease using the standard criteria is always so secure. In other words, could there be other diseases masquerading as Behçet's disease, perhaps driven by monogenetic diseases? So you've heard already that this is a disease that has a particular geographic distribution in terms of its prevalence being much more common along the so-called ancient Silk Route. So for many years, people have been of the view that there could be a genetic component to common or garden Behçet's disease, perhaps not in a monogenetic way, but rather as a complex disease with a polygenic predisposition. And many of the genome-wide association studies that have explored this have indeed found important genetic associations. The problem that you have with any disease such as Behçet's disease is that the symptoms and the signs are in fact rather non-specific. By putting these symptoms and signs together and excluding many other things that could cause oral ulceration or pyoderma or uveitis, you hope to derive at a secure diagnosis, but life is sometimes not so simple. So the challenge that we face as clinicians is that the clinical features can be completely non-specific. There is no laboratory diagnostic test, and therefore we have to rely on clinical criteria to aid the diagnosis. One of the earliest so-called diagnostic criteria were those proposed by the International Study Group, as others have mentioned, listed here. And more recently, we believe that the international criteria are perhaps more accurate for children, but by no means perfect, where a score of 4 or more of these features here might indicate a child with Behçet's disease and give you confidence that you can treat accordingly. However, all that glitters isn't gold. So in terms of what's known about the genetics of Behçet's disease, most of this has been derived from genome-wide association studies, where inherent to that methodology, very rare genetic variants, in other words, monogenic conditions, would be excluded, because what you're looking for are variants that occur in more than 5% of the population that may confer a risk of developing. And when you apply that very powerful technology, HLA-B51 is the most strongly associated HLA genetic association, although other HLA genotypes have also been reported, like A26, and there have been some other non-HLA loci described, such as ERAP1. One of the emerging views is that Behçet's disease may share some of this non-monogenic predisposition with another relatively common periodic fever syndrome called PFAPA, periodic fever, aphthous ulceration, pharyngitis, adenitis, an illness that's a common cause of non-genetic periodic fever in children under the age of 5. And in fact, there may be a spectrum of patients with just recurrent aphthous stomatitis, PFAPA, and at the severe end of the spectrum, Behçet's disease. But really what we're talking about here are those patients who do not fall within that spectrum of complex, common or Gordon Behçet's disease, but rather have another immunological genetic diagnosis that may be mimicking Behçet's disease. And one of the earliest reports of that this was a proof of principle and true was the first description of the dominant disease called haploinsufficiency of A20 caused by loss of function mutations in a gene called TNF83, first reported in 2016, resulting in a dominant form of an illness that would satisfy all the diagnostic criteria for Behçet's disease, with posterior uveitis and oral ulcerations shown here, and skin rashes and positive pathogy, amongst other systemic inflammatory features. But life is not so straightforward, so let's consider a case. This is a real case. This was a 15-year-old male who presented to us with recurrent oral ulceration more than 3 times a year, without uveitis or genital ulcers, but with paniculitis. He had some degree of systemic inflammation with an ESR 40, CRP ranging between 30 and 40, the normal limit being less than 5, and indeed on subsequent examinations had mild terminal ileal ulceration, but not with a pathology that was indicative of Crohn's disease. He then, sometime into all of this, presented with grand mal seizures and was found to have a sagittal sinus thrombosis, and the diagnosis of Behçet's disease was considered. When we apply the ICBD criteria, where you need a score of 4 or higher to make the diagnosis for this particular case, we could definitely say he had oral apoptosis, skin lesions, and vascular manifestations by way of sagittal sinus thrombosis. So if you tended to believe these types of tools, which you'd be entitled to, he would score a score of 4 and be safely diagnosed with Behçet's disease. So based on that, and this was a number of years ago, he was treated with aspirin, anti-aggregant doses, anticoagulated with heparin and later on to warfarin for 6 months to treat the sagittal sinus thrombosis, was treated with corticosteroids and anti-TNF, which is available at the time. Being a paediatrician, we were able to hand over his care, but at the age of 25, I was contacted again to provide some commentary on this case. Over time, anti-TNF had been stopped by his adult physicians because it had been less effective over some time. He had had a recrudescence of his symptoms, which included anemia, fever, lymphadenopathy, aches and pains, myalgia, and a biopsy suggestive of myositis. We offer a gene panel test that's colloquially known as the Vasculitis and Inflammation Panel, or VIP for short. And that was one of the specific requests asking whether or not this boy may have an alternative genetic diagnosis mimicking Behçet's disease. What we found on that panel was a heterozygous pathologic mutation in GLA, an absence of leukocyte alpha galactosidase activity, confirming the diagnosis of the metabolic disease, Fabry disease. This is an X-linked lysosomal storage disorder where enzyme replacement is available. Autoinflammation is recognised in Fabry disease, driven by glycolipid accumulation, which is recognised as a danger signal within white blood cells. Thus, Fabry disease joins other emerging lysosomal storage diseases that recently have been associated with an autoinflammatory phenotype. And in fact, venous thrombosis is a recognised complication of Fabry disease, emphasising that these features also described in Behçet's disease are non-specific. So this led us to investigate other patients who presented to Great Ormond Street over the years with a diagnosis initially of Behçet's disease, who turned out to have an alternative monogenetic diagnosis. And this is some data that's been published in Rheumatology Oxford in 2019. And what we found was a range of mutations in patients who had a phenotype suggestive of Behçet's disease but had an alternative diagnosis, sometimes with important targeted treatment. We did indeed confirm the presence of 2 cases of haploinsufficiency of A20, but other novel forms of autoinflammation caused by this gene, chronic granulomatous disease, 2 different forms in 2 separate patients, and a whole new disease called periodic fever, immunodeficiency, and thrombocytopenia caused by recessive mutation in WDR1, an important gene involved in the regulation of the actin pathway. There were various other metabolic diseases, Fabry disease I've mentioned to you, and other autoinflammatory diseases, emphasising that some patients with these monogenetic diseases, in fact, could present with what looks like Behçet's disease. So of 11 paediatric patients, one of the red flags was an atypical presentation and/or presentation before 5 years, perhaps indicating that there could be a monogenetic disease. We identified that 2 had 9 classic known disease-causing variants, and 2 had novel variants highly suggestive of a monogenetic disorder. Since that publication, there have been many other reports of monogenetic diseases spanning immunological diseases predominantly that can present as Behçet's disease. So this has led to now a new PhD. This is Alice Burley, a UCL PhD student who's in the 2nd year of her PhD. And she has a simple hypothesis, is that a proportion of UK Behçet's disease patients, children or adults, in fact, may not have Behçet's disease, but in fact do have an underlying monogenetic diagnosis. So the aims of Alice's project are to facilitate searching for this in a UK cohort of patients with Behçet's disease, where previously there was no genetic diagnosis explored for those individuals. Alice is using state-of-the-art functional laboratory readouts to confirm and refute the pathogenicity of any of the genetic variants that she may find. And we propose that this will facilitate logical and more targeted therapeutic decisions. And we may, of course, also prevent harm by reducing the burden of immunosuppression by identifying even better targets, such as the case of Fabry disease that I shared with you a bit earlier. Whole exome sequencing can provide quite a lot of information, and there are 3 broad strands to this. First and foremost, automated, more sophisticated means of looking for pathologic variants based on this script that Alice has written, and also the program Exomizer, which links phenotype with the genetic variants identified in specific individuals and prioritises them. But of course, for many patients, there will not be a monogenetic disorder, and it may be that there is in fact an HLA type, more suggestive of classic Behçet's disease. And the good news is that using this work package called OptiType, you can use the whole exome sequencing data to generate that information at the same time. So at the end of this, you will have a scrutiny for monogenetic disease and also an HLA readout that can at least let us understand the genetic architecture of your individual patient with a Behçet's-like phenotype. So in summary, we propose and will remind you that some patients with Behçet's disease have a different diagnosis caused by single mutations in genes spanning the immune system and perhaps more broadly. Next generation genetic sequencing can detect these and may guide more precise treatments. Next generation sequencing can also provide an HLA type, including HLA-B51, that's known to predispose to common or garden Behçet's disease. And whilst we're waiting to understand better the proportion of patients where this applies, my personal practice is that all children with suspected Behçet's disease should have genetic testing with next generation sequencing. Thanks very much.
A huge thank you to our presenters for that fantastic presentation. We will now have a Q&A session and the presenters will answer the questions that you've submitted. Thank you.
Hi everyone, I hope you can all hear me. It's great to see that we have 115 attendees, so we've had quite a few questions. So what I'm going to do is go through the questions that are published on the Q&A, and you've got all of the expert panel at your disposal, and we can share the answers amongst us. So the first comes from Helen Oliver, who's asking about when a child has been traumatized because it may have taken them a very long time to get the correct diagnosis and therefore to achieve the right treatments. What other support can we offer children to offer them a better quality of life where there's already been damage done and children currently have a poor quality of life? Rob, do you want to take that one?
Yes, thanks for that, Paul. So it's a really important question, and it's very frustrating to see all of the trauma and the baggage and problems that accrue with Behçet syndrome, whether it's a child, a young person, or an adult. I think there are two things worth saying here. I think the number one is to get a diagnosis quickly. Because the sooner we have a diagnosis, the sooner we know what's going on. And of course, in the case of, for example, genital ulcers, then any potential infection, all the various issues with that get taken away. So think about the diagnosis, make the diagnosis, institute treatment, and that can minimize a lot of problems. The second thing is something that we're very fortunate in the adult service, and that's to have a dedicated clinical psychologist that could be working alongside the patient. And I know it's a little bit more challenging in some of the pediatric settings, but by able to access, both for the child, the young person and their family, appropriate clinical psychological care can also make huge differences, as you might imagine, in these difficult situations.
Thanks, Rob. That's excellent. Emphasises the importance of psychology for any chronic disease, but particularly Behçet's disease. We've had a question in, maybe to Daniel or to Robert or to myself. Do we think there'll ever be a laboratory diagnostic test for Behçet's, or are we always going to be reliant on clinical acumen? Tell us the answer, Rob.
Well, I think it's a tricky one. If I knew the future, I'd do the lottery, and I don't do the lottery. We're kind of banking on people like you, Paul, with all the sequencing to come up with that. My hope is that we will get better at making a diagnosis. There are many different diagnostic criteria for Behçet's, and that tells me that we're rubbish at making the diagnosis. So there's a lot more work to be done with clinical phenotyping, all the clever genetic stuff that you're doing. And who knows, it would be great if in the future we can actually have a test. Paul, what do you think?
Well, I agree with you, Rob. I was Claire and I, when we were helping set up the surveillance, we came to the conclusion that there may be more sets of diagnostic criteria than the number of actual patients that we look after, which tells us, yes, we're really rubbish at this. So I think what I've learned after 15 years of being involved in genetics is that clinical acumen is always very important, no matter what uber-duper genetic or laboratory test you have, because it's largely meaningless unless there's the correct clinical context. And this is true for all screening tests, where the predictive value of a positive test is entirely dependent on you doing that test in the right population of patients. So I think my honest answer is don't hold your breath for any single test, but do keep an open mind, make clinical diagnoses, but always be prepared to be wrong. In other words, if there is Fabry disease, accept that and move on. Okay, we've got another question. Should all patients now, children or adults, should all patients have a genetic test for Behçet's disease? What do you think, Rob?
I think that's a really good question. And what you're showing, Paul, with your work is that there are significant mimics that can be picked up with, I suppose, mixed generation sequencing, certainly next generation sequencing. And that's clearly important as we understand about what constitutes the phenotype of Behçet's. And that's going to be very important if it might actually lead to different targeted treatments for the different genetic variants. In the case of adults, we're not quite as well funded as you with regards to all of the sequencing. So that's a little bit more challenging for us. And I think I'd really revert to you just supporting your comment, Paul, that clinical acumen is really crucial here. And until we understand more about the pathophysiology, certainly from the adult side, where we see a higher frequency and prevalence, genetic testing is appropriate for people that have a disease that just looks wrong. But I guess from a pediatric angle, as you've been demonstrating, that genetic testing can really be enhancing things quite a lot, but not replacing clinical acumen.
So that's a great answer. Thank you, Rob. So linked to that discussion, there's a question in, is there a Behçet's genetic panel for next generation sequencing, or are you offering whole exome sequencing on all of them? Okay, so I'm very happy to take that. So what's really important when you design these panels of tests is to rule in positive diagnoses, but also to rule out important mimics. So on our vasculitis and inflammation panel are many genes associated with diseases that any person in the right mind would say, why on earth is that on a vasculitis and inflammation panel? The answer is that doctors, on the whole, are rather more stupid than we think we are. So, for example, one of the diseases that I'm often referred is large vessel vasculitis, Takayasu arteritis. If I'm being very honest with you, for a disease that can sometimes be associated with normal inflammatory markers, half the time I don't even know if I'm dealing with a genetic vasculopathy causing complete thrombosis of both femoral arteries, as was the case on Friday in a 6-month-old baby, or whether it's a true large vessel vasculitis. So a good panel will rule in positive immunological diagnoses, but will also exclude important mimics, for example, Fabry's disease. And in the past, when you applied whole exome sequencing in a clinical setting, you went down lots of blind tunnels, but the technology is now such that every patient can now have quite easily whole exome sequencing, but with a targeted panel scrutiny of that data. So if you do not find an answer on your panel, maybe next month when a new gene is discovered, you can have another look and you will find the answer. So the answer is whole exome sequencing and judicious application of a panel to rule in and rule out important mimics of the diagnosis for Behçet's. So Rob, here's a question for you. 2 questions. How long should biologics be given? And if you're given biologics for a long period of time, what on earth do you do if you lose efficacy of that biologic?
These are crucial questions that we really struggle to give a good evidence-based answer. Biologics, at least with regards to the National Centre funding, we will fund a biologic for a period of 6 months unless there's CNS disease, ocular disease, or vascular disease, in which case we feel that 2 years is an appropriate duration. There's no huge great evidence to suggest that, except that we know that vascular, CNS and ocular disease can lead to really bad outcomes. Therefore, we intuitively need to give drug for longer. Saying all of that, many people, once they've got a patient on a biologic, would try and stop it after a few months, a year or whatever. But almost inevitably the patient will flare up. So what we need are trials of actually discontinuing or tapering down biologics. We don't actually have any of those, and there's a huge need for that, just to help inform exactly that question. And what do we do if a response to a biologic is lost? Well, we worry, because our patients worry. They've been very ill, they've put on a fancy new designer drug that's going to do everything and make them better, which of course it does usually, but then it stops working. So those really are challenging things, and it could be development of anti-drug antibodies, for example, to a TNF inhibitor, and sometimes swapping the TNF inhibitor may be helpful. As I mentioned in my presentation about phenotyping patients and actually targeting different cytokines for different types of phenotypes, this is the type of approach that we're taking at the moment. And what might be nice would be to have some sort of genetic screening, not so much for diagnosis, but actually for targeting, predicting response of treatments, and actually try and get the right drug to the right person at the right time. But these are all very concerning issues for our patients who've got better and then are struggling.
Great answer. So folks, what you're hearing is that it takes an expert to know when to start treatment for Behçet's, but it takes a real expert to know when to stop. And that's Professor Moots for you. Definitely, he's the expert here. Okay, Rob, here's another much more difficult question. You've done all of that. You've done all your precision medicine, your targeted treatments, and nothing has worked. What do you do then?
Worry is the short answer. We don't have, thankfully, many patients in that situation. We can normally find a drug or combination of drugs that will help. The worry is that some patients end up resorting to glucocorticoids. They're on steroids, on high-dose steroids. It buys some response, but at the price of terrible adverse effects and things. So what we've done in that type of situation is go to human stem cell transplant and autologous peripheral stem cell transplant. We've had 5 patients now, which is the largest series in the world, I think, in adults having transplants for Behçet's, and every single patient has done well. It's kind of dramatic, it's kind of scary, it's certainly not without significant risks, but for the very exceptional patient in this very difficult situation, we found that that can be successful.
So a reboot of the immune system, giving them back their own autologous cells, but hopefully in a naive way, and hope that their HLA type, which is just the same, doesn't catch up with them in years to come.
And keep your fingers crossed.
Right, now I had to really think about the abbreviations here. It's clearly an excellent paediatrician who asks, what about the chance of occurrence of Behçet's disease in twins, either DCDA or MCDA? So I had to put my brain back into neonatal life and work out that that's dichorionic diamniotic, so in other words, non-identical, or monochorionic diamniotic identical. So I'll take that one. So when you apply genetic testing in terms of HLA status for autoimmune diseases, you can find associations, but these associations are rather weak, so weak in fact that you cannot apply an HLA-B51 test to the population and say, you've got HLA-B51, therefore the chances are that you will develop Behçet's disease. The actual absolute risk is so small. So for the DCDA twins, they're just like a brother and sister, or 2 brothers who are not twins, so very, very low risk. For identical twins, of course, there may be a slightly higher risk because there may be other genes that are shared in common, but overall the genetic risk for common or garden Behçet's disease in terms of absolute risk is rather low, and you could counsel your patients that in fact most of the twins would not have a problem. If you do see a problem, that should perhaps prompt you to consider a monogenetic disorder is the simplest answer, I think. Anything to add to that, Rob?
No, I think that's very comprehensive, entirely appropriate, Paul.
Okay. So we've got a question from someone called Nadia Yamamura. Do you think a virus or other infectious agent might be involved, especially if an HLA type is highly prevalent? So infectious triggers, Rob, recognised?
Everybody thinks that there must be an environmental trigger, which clearly would be important given the relatively weak genetic associations understood so far. The problem is nobody's really been able to work out what that infection trigger is. There's a lot of different stories. For example, some people think about oral hygiene, gingival health, perhaps reduction in Behçet's in countries around the Silk Route where dental hygiene is improved. But then you could probably say the same thing for many other things. Certainly, we do think that it's handling some sort of microorganism abnormally, and that's what we're seeing when we do these famous pathogy tests, where you just prick the skin, and some people with Behçet's get a funny reaction there. So exactly what the microorganism is, we don't know, but it would make sense that that could be interacting with the genetic susceptibility and triggering disease.
That's a great answer. I think I agree with that. And as ever, for the audience, when you're considering autoinflammatory disorders, humans really want to find an infectious trigger. But remember, this is probably autoinflammation. You don't need to have an infection to trigger autoinflammation. It could be stress, sleep deprivation, change in the microbiome without an infection, or indeed an infection. There are many things that can trigger autoinflammation, is the way that we think about it. Now, the next question I like very much, because the person who asked the question answers the question for us. So Anfield says the key to early diagnosis would appear to be wider dissemination of knowledge of Behçet's amongst primary care, as this can lead to delays. I agree, and that there's a perfect question which answers itself. Okay, Helen Oliver is asking another question, another great question, and a very important one, so I shall read it out. So Helen asks, when you already have a diagnosis and have trialled numerous medications which have done so much damage, which impact on top of the actual disease Behçet symptoms, including osteoporosis, spinal fractures, she makes the point that no treatments are safe. Blood monitoring can't necessarily make sure that the 20+ medications that someone is taking are not doing harm. So her basic question is, how do we move forward with treatments, Rob? In the adult world, how do you move forward?
I think the crucial thing is to look to do good clinical trials to actually explore not only new treatments, but also optimal way of giving existing treatments. I think that's really going to be key to move forward. And in parallel with that is understanding the disease process better and see how we can actually more strategically target treatment. These are all big things. We've not been great at doing them, but we are all starting to be a lot better at that, both in the adult world and also by planning and taking part in clinical trials for children and young people. That's a very important advance.
That's a really important point. So clinical trials is always the answer to that question. And it's okay to do clinical trials in children. In the past, you know, many of us have come across, you know, is it ethical to do clinical trials in children? The answer is it's unethical to not do clinical trials in children for these types of diseases. Okay, we're coming to the end. The questions are flooding in. It's always the same. So I'm going to do some quick questions and rapid fire answers, Rob. We'll take them alternatively in no particular order. So the first one is, what's the best genetic test? I'll take that one. Whole exome sequencing with targeted scrutiny, so you can get an answer in a timely fashion. Second question is, if you are tested positive for B51, but you've had a septic arthritis without any of the other features, can you diagnose Behçet's disease? So what's the likelihood of form-fruit Behçet's if you're HLA-B51 positive, Rob?
Unlikely. I don't think we should get carried away about that particular MHC type. It is not diagnostic. It's useful adding into our algorithm for things, but on its own, don't worry about it.
Yeah. Quick question here. If you've got a monogenetic diagnosis such as familial Mediterranean fever, but with Behçet's GI manifestations, chronic tummy pains, what would be your first choice of biologic for controlling the GI manifestations? So I think we've heard from Rob that anti-TNF would be a very good choice. So even if your genotype is telling you one thing, I think that, as Rob says, and I agree with, that the phenotypic approach is very common. You have to remember that in familial Mediterranean fever, abdominal pain can be a feature. So make sure you're dealing with a vasculitic cause, you know, histology that would be compatible with Behçet's. Another question from Nadia Yamamura. Oh, that's probably not. I was wondering if you use colchicine as a drug for Behçet's, Rob?
Yes.
Yes.
Colchicine is very useful for many aspects of Behçet's. It's well tolerated in very low dose, and it's a mainstay of treatment for many patients.
Yes, for us, it's the second on the list in terms of the therapeutic ladder for Behçet's, so same for children. There's an anonymous question here that says, I got tested through a lumbar puncture and then got a positive result for B51 and was given a diagnosis. This sounds like someone who's a patient, but I haven't had any other testing. Would I need to do more genetic testing done to be sure that it's Behçet's that I have? You can discuss that with your doctor. The way to pitch that question will be to say, look, we've just had this webinar. One of the research questions is, do doctors always get the diagnosis correct, or could doctors have maybe gotten the diagnosis wrong, not because they've done anything wrong, but just because that's the way advances in medicine take place, and discuss the possibility of linking in with your centre of excellence. And if you do that, you may be able to get access to this via a research programme. So for rare diseases, I think research can help in day-to-day care for some patients. And then the last question is from Tony, who's the chair of Behcet's UK, who says, thank you everyone for such a comprehensive and informative webinar, really helpful. So I think probably, Rob, we can take that as a seal of approval from the patients and stop there.
Thank you.
Thanks very much, everyone. It's a shame we can't see you all, but I think this type of webinar lends itself well to pandemics. I think that the idea is that these answers are also going to be published and you'll be able to look at them in your own time. I'll stop talking now.
Really good fun and really useful, nice format. Thanks.
Thank you again to Dr. Payne, Dr. Finn, Professor Moots and Professor Brogan for the presentation, and thank you to everyone for joining us today. We will be in contact with all registrants by email to share the recording of today's webinar and also a link to the online post-webinar evaluation form. We have posted a link to the evaluation form in the chat. We would be very grateful for your feedback. Thank you. We hope you will join us for a future RCPCH-BPSU webinar. Thanks again.